So we turn to our final section in this really very interesting conversation with both of you. From my perspective, very important. And that's the topic of, we've alluded to, but very specifically talk about this, the issue of recurrence. Patients doing well, feeling well, and there's evidence the disease comes back. Justin, a little bit about, you sort of alluded to the potential of recurrence. How do you discuss this with patients, their families? How do you detect it? What do you do next?
Sure. So, we take the patient who comes in stage 3 or 4. We do surgery. We do chemotherapy. We achieve a remission. And at that point, we don't elect for maintenance. And we are observing and following the patient up with surveillance. And part of it is during their surveillance visits, patient may be feeling perfectly well. We talk about what to watch for, symptoms to be in tune for, going back to their original diagnosis. If you start to experience that bloating, that nausea, if you start to have that low back pelvic pain that you had 4 years ago, we need to know. And so part of it is talking about the symptoms, talking about the risk of recurrence so that the patient is aware of that high risk, so that we're vigilant as we can be going forward. Then when we're faced with the recurrence, as I mentioned, it changes how we talk about the disease treatment strategy, because we're not talking cure, we're talking treatment. And our goals of treatment, what do we want to do? We want to extend survival, but at the same time, we also have to preserve a person's quality of life. I do you no favors if I give you a combination of drugs or therapies that you can't get out of bed for a week or a month, or you end up hospitalized with a complication of the treatment. So we really start to have to temper what are the treatment side effects, what are the disease side effects, and what are realistically milestones that we can achieve. And as I mentioned, the recurrence at 3 months is very different than the recurrence at 3 years in terms of what we can expect and how we approach treatment.
So one of the questions that comes up is this therapy versus observation, watch and wait. Obviously, this is a conversation with patients, but how do you approach that conversation about the potential value of continuing therapy? Because obviously a patient has responded to therapy, they've gotten platinum, whatever, and they see the benefits of it, on the other hand, side effects. How does that conversation go with patients?
So the assumption being, okay, we've achieved a great response, and, if it's the first line of therapy, a lot of times those patients are more ready for a break, and they've been through surgery, they've been through chemotherapy for weeks or months, they've experienced side effects and toxicity, so those patients may more be ready to take a treatment break to go with watch and wait, as opposed to trying maybe a maintenance therapy to see if we can extend that remission or their progression-free survival. With the recurrence setting, because patients know, okay, I'm going to be now dealing with this all the time, whether it's following up or whether it's active treatment, then I think the conversation may lean more towards, all right, we're achieving a response. What can we do that will have minimal impact on your quality of life, minimal side effect, but still maintain the response we're seeing? And that's where the benefit of maintenance therapy can really play a role for a patient, because stability, keeping something in check, can actually be a good outcome if we can do that with minimal toxicity, minimal side effects, minimal impact on a person's quality of life. The hard part is, we don't know the severity of side effects until we try. But it's sort of a very individualized discussion, and some patients will come in already having done their research and their homework and kind of know that yes or no they don't want. Others, it's an open-ended question where we present pros and cons to each. And a lot of times it's we're going to talk about this today. We're not making any decision. We'll talk about it today. I will call you next week, or you'll come back in the following, and then we'll sort of make a plan as to how we wish to proceed with either maintenance or surveillance. And then the question is, what does surveillance look like? Do we use a CA-125 test as part of surveillance or not? Do we just do physical exam and a careful history every 3 months? So those are questions then that we address on the individual level.
So one of the, sort of just to follow on what you said, one of the, again, going back to my own experience over several decades now, when we talked about the therapy, we were talking about some pretty toxic stuff. the platinums are incredibly wonderful drugs. The taxanes are incredibly wonderful drugs, but they have an awful lot of side effects. So the concept of maintaining was very difficult. With the drugs that we have today, we can begin to have that conversation, not only maintain that response, but maintaining that response with really impressively positive quality of life. So it obviously adds a whole nother part of the conversation. It's, yes, not only can we maintain it, but from the point of view of the impact on the disease, but maintain it from the positive impact on the quality of life and allowing you to do what you want to do while still potentially taking therapy. And that's obviously an evolving concept that we're learning. And of course, the data, the randomized controlled trial data are really quite impressive in that regard.